All right, Kathy, you ready to finish our PhD course in change management?
Yes.
Good afternoon, folks. It looks like we're getting the usual crew back together for our final part 3 of our change management series, and so this will be the final installment, if you will. All of these are being recorded and have been recorded and are on our website, so if you have other staff or want to go back and refresh your memory, they are there for you. We're thrilled to finish with Cathy, who's been leading our work and has a lot of experience in Oregon around change management and Medicaid transformation. And some of you are familiar because she works with us a lot around our contracts with you folks. So happy to have Cathy with us. And with that, let's finish on a high note, Cathy. So I'll turn it over to you.
All right. No pressure.
No pressure.
Hi, everybody. Nice to see you all again. I think you guys, the guys who are on this list, have been on before, so I'm not going to say anything else about me. So our agenda for today, third and final episode of Change Management series. So I'm going to do a quick refresher of change management principles and then just make clear the definition of quality improvement and quality assurance and what they have in common and how they're different. And then we'll look at some QI models. And then I'm going to share some really helpful practical tools. And then we'll end with some key themes across the models and tips for success. And we should have some time for Q&A at the end. So with that, I am going to launch into it. So as a reminder, change is hard. Most change management efforts fail. So a whole school of thought around change management has been developed, and it is a systematic approach to help people and organizations successfully implement change. It is not the same thing as project management. Project management is the technical side. Change management is the people side. When I did our initial presentation about change management, this is one of the slides I put in front of you, talked about, well, why do so many change management efforts fail? And you'll notice that I've highlighted in yellow 2 of the reasons, because they're really what we're going to be talking about today. Efforts fail because there isn't a measurement plan in place and there's no mechanism for short-term wins to keep energy going. And so quality improvement is really your tool in the toolbox for making sure that your change management efforts don't fail because of either one of those reasons. So let's talk about quality improvement and quality assurance. So quality improvement is another systematic approach to analyzing performance in an organization. It's really about designing, testing, monitoring interventions that lead to some kind of measurable improvement. It is not the same thing as quality assurance. QI and QA are often talked about in the same breath, but QA is different. Quality assurance is a systematic way to make sure that whatever standards you've set in the past are being met. So some examples of QA could include any kind of quality control. Maybe you're doing consumer satisfaction surveys. Accrediting and credentialing are both types of quality assurance, making sure that a provider or a clinic is meeting standards that have been set. Or utilization review. That's another example of quality assurance.
Hey, Cathy, we're still on slide 1, and I get the impression you should be a little bit further down the slideshow deck.
Yes, let's see what's happening. I might stop screen sharing and restart. See if that fixes our problem. Sorry about that, guys. Okay.
There we go. Thank you.
You see different things? Okay. Here's the slide I wanted. Okay, so here's a sort of side by side about the differences between QA and QI. Quality assurance, again, quality assurance is really about compliance. We've set standards. We want to make sure that we're meeting those standards, because that's one way that we're gauging whether or not we're providing quality services. So assuring quality through standards and compliance, it's a reactive approach, kind of looking back to see where you didn't meet the standards that you had set. It's focusing on individuals. What individuals in the system missed steps or didn't meet standards, they're really specific fix. Next time, don't miss that step. It's evaluating the current way of doing business, and it asks, do we provide good care? Whereas quality improvement, which is going to be the focus of our conversation today, is really about raising quality by improving processes to meet standards. It's a proactive approach. It's looking forward for opportunities to improve quality. It focuses more on teamwork than on individuals. It requires continuous efforts. It's not a one and done. We don't check the box and say, yep, we've met it. It's really becomes a way of practice for an organization. It tests new approaches, and it asks, how can we provide better care? How can we provide better services? Not, are we? There are some similarities. So both are based on some standards for performance. They're both about improving the care that is provided or the services that are provided. And they are both really useful tools for organizations in managing change. So it's not that QI is better or less boring than QA, though sometimes people feel that is true. Both are really useful tools. You just use them in different ways for different things. So let's talk about some quality improvement models. There are a bunch of models, just like there were a bunch of models around change management. We're going to look at the three most common two. The first two are usually highly related, Lean and Six Sigma. And then we'll also look at the model for improvement from IHI, that PDSA cycle. And just like with the change management models that we went through, it's really important you choose something that's a reputable, proven model, but it kind of doesn't matter which one you pick. It's more important that you really follow through and commit to the practice of that model. Okay, so let's start with Lean. I'm going to do quick overviews of Lean and Six Sigma. There are people out there who devote their lives and their careers to Lean and Six Sigma. I am not one of those people, so this is going to be a high-level overview. So Lean, which really was started by Toyota as a tool to streamline manufacturing and production processes. So building a car, how can you use Lean to make the process of building a car better? The main emphasis is on cutting out unnecessary and wasteful steps in the creation of a product. It's also applied to the delivery of services, so that any step you take is only the steps that are bringing value. If there's a step in a process that isn't bringing value, the Lean model has you take that step out. And the focus is really on the value to the customer or to the client, with minimal wasted time, effort, and cost to the person who's providing that service to the customer. So a key step in a Lean process is starting with what's called a value stream map, VSM. And it really is just a visual representation of every step in the flow of a process. Other models would just call this a flow chart or a system process. In the Lean model, it's called a VSM. A team needs to come together to develop the map and come to consensus about all the steps in the process. A VSM is not something that just one person can do in an organization. It really is meant to be a team, so that you're getting a wide array of perspectives and people who know all the steps in a process and where they connect and where they don't. So it's really useful for mapping steps that a patient or a client goes through to get care or services. And when you do this process, the team can then identify, okay, where are there places where there's waste, things aren't flowing the way they should, there are errors, there's duplication, there are gaps, losing pieces of information. Here is an example of a value stream map for a patient coming in for surgery, starting with their check-in. You can see at the bottom, you see the flow of the patient through all the steps from check-in to recovery release and going home, and how it connects with the information systems up above. Here's another example of a value stream map. This one is, you know, a much smaller level, narrower focus, and it's really about, okay, here's a patient, you know, starting with when they pull onto our property for an appointment, how much time does it take for them to have the appointment and to leave? And really trying to identify in this one, what are the waiting points? Because those would be considered the places for improvement. Value stream starts with a storyboard, so whiteboard, Post-it notes, a group of people coming together and really step by step by step by step mapping out the system. So after you've done your value stream mapping in the lean model, you then move into the 5S organization. And 5S is really about the work environment and making it, quite frankly, neat and clean and tidy. 5S is about improving the space organization, eliminating any environmental factors that get in the way of the workflow. If the file, let's pretend we're still using file cabinets, if there's a file cabinet with patient or client information that's, you know, 3 offices away from me that I need to access every day in order to serve my clients, that's getting in the way of the time that I have to meet my clients' needs. So starting with you sort, you get things in order. Shine is really about cleaning things up, standardize your materials, and then sustain the practice. And it sounds a little silly, although I would very much like to be able to successfully implement 5S just in my household. I don't have a team that is willing to implement or sustain that with me. It sounds silly, but the 5S's really have been demonstrated again and again, and not just in a manufacturing setting, but in a service setting, to really help along with the mapping in creating processes that bring more value and just have less waste and fewer steps that don't bring you anything. Another graphic around the 5S's. Really, you know, this comes from Japanese businesses, and so imbued with some Japanese culture around what the physical environment should look like. So another important component in the lean model is really on culture. So there are these steps you go through, but then the culture of the workforce also matters. There should be interdisciplinary teams where leaders are coaches and enablers, not top-down telling you how you should do things. Decisions should be data and process driven. Strong focus on the patient or the client, or in the original model, the consumer. And when you make process changes, they may also benefit the team or the workers, but that's not the focus. The focus is really about creating benefit for the client or the consumer. So that's lean. Now I'm going to talk about the 6 Sigma model. And when I get through the basics of the 6 Sigma model, I'll give you an overview of how the 2 models are connected and why they're often talked about together. So 6 Sigma, the 6 in that little symbol is the Greek symbol for Sigma, is a model designed to eliminate defects and waste. And the idea is that thereby improves quality and efficiency. Sigma is a statistical term. So the 6 Sigma rating is really about getting to, it's the highest rating, and it's about having a process that results in 99.9999999% of your products or your services being delivered without defects or without problems. Also first designed in manufacturing, but has been used very, very widely in healthcare, especially in large health systems, hospitals. And as I mentioned, it's frequently used in conjunction with lean. GE really first in the US implemented the use of Six Sigma and touted much success, and that sort of made Six Sigma be the hot change management tool of the day in the early 90s and since. So there are 5 key principles in the Six Sigma model. One, just like with Lean, you gotta focus on the customer. For us, I'm gonna talk about patients or clients, but really this is about taking a patient or client-centered approach, and quality is really viewed through their eyes, not through the system's eyes or the provider's eyes. Start by mapping and measuring the process to find out where the problems are. So as with the visual system map that you do in Lean, there's a mapping here augmented by gathering data on how the system works. Once you've got your lay of the land and the data behind it, then you work on getting rid of the junk. What changes can you make to eliminate either places where there's too much variation, meaning you're going to get different outcomes because the system isn't being implemented in the same way across the organization, or where are there steps that aren't bringing value and need to be pulled out? Once you identify that and you clear out the steps, the next principle is keeping the ball rolling, really engaging the team and all of the members of an organization in the change, all of the stakeholders. This is, again, building on the themes that we heard in the first change management presentation, where change is something that happens with people if it's going to be successful, not to people. And then lastly, creating an environment, a culture that is flexible and responsive. Improvement is not a one-time change. Improvement is a way of life, and it's to be expected that change will be continual in order to continuously improve, and you need a culture of people who are flexible and adaptable and responsive and comfortable with change. It doesn't throw them into chaos. So the methodology, there are a bazillion acronyms in Six Sigma. There are a bazillion tools for Six Sigma. It really has become this, whole sort of industry in and of itself. I'm just going to kind of give a brief overview, but the methods, really two acronyms for the methods, and it depends on, are you talking about a system or a process that's currently in place that you want to reevaluate and improve, or are you talking about a new system or process that you need to create? So I'm going to focus on the DMAIC, which stands for Define, Measure, Analyze, Improve, and Control. This is the life cycle of a change, using data to improve outcomes for patients or clients. The second acronym, the only change is with the last 2 letters, where it's around design and validate, and that's because you're creating a new system that doesn't already exist. So for our DMAIC, you start by defining the problem. What's the problem? What's the scope? Who are the stakeholders or the team that you need to pull together to help you develop a plan? Then next step is collecting your data, measure. What's the magnitude of the problem? What's the actual situation? What do you need to do in order to understand how much change is needed? Then you move into analyzing your data, mapping the process in detail, researching the root causes, and figuring out, okay, what are the most influential factors? What are the key levers? There might be 10 reasons why our process is experiencing a problem, but there are probably only 3 of them that matter most. So what are the key levers? Then once those are identified, you can move into your improvement process, developing your solution, creating a change plan, and testing it through a pilot. And then the last phase is control. Once you've tested out your improvement, this is really about monitoring and maintenance. How can you make sure, how can you spread it? How can you make sure that the change that you've made will stick? So this visual just gives you a quick glance at the number of tools that have been created for the Six Sigma model. For each one of the steps in the process, underneath it, you'll see a list of the common tools that are used. In the definition phase, there's a tool around hearing the voice of the consumer, the customer, a matrix for cause and effect, all kinds of checklists and charts. And in the end, I think a lot of it is common sense, but there's a whole industry behind Six Sigma, and hence a whole bunch of tools that are available for purchase. In addition to all of the tools, there are also levels of skill and knowledge. You go from a white belt up to a blue belt. When you are implementing a change process in an organization, the rule of thumb is supposed to be that only green or black belts are overseeing that. The white and yellow belts are participating in it. And again, there are training programs out there, and some folks really believe in and buy into the Six Sigma model and have invested a lot in training and have demonstrated results. So Lean and Six Sigma. It's a lot of overlap. It's kind of confusing because sounds like sometimes they're talking about the same thing, just using different words. So, an easy way to think about it is Lean is about creating value by minimizing waste. How can we get rid of any unnecessary or wasteful steps in our process? Whereas Six Sigma is about getting rid of defects, solving problems in the process. And when you put them together, it's supposed to accelerate the process. And so I think at this stage now, any kind of Six Sigma approach is typically always a Lean Six Sigma approach, and using elements from both models. So now let me talk about the science of improvement. Talked about this briefly in the 101 on change management models. In the world of healthcare, the Institute for Healthcare Improvement has done a kind of work to develop tools, develop trainings, and educate the healthcare workforce around the science of improvement and their PDSA cycles, which we're going to talk about in a little bit. I think in the community-based organizations, social service side of the world, still a little bit behind the curve on the science of improvement, but more and more the method is being applied, and I think very helpful. So as I mentioned, it's been used successfully by hundreds of healthcare organizations in many, many countries around the world. The process can be used for small changes to large system changes. It doesn't necessarily replace any of those overarching change management models that we discussed in the first webinar, but it's a tool to help accelerate improvement within those models. So the model has two parts. We're going to look at them in just a second. First part is you got to answer 3 basic questions. Doesn't matter which question you start with first. And then once you answer those questions, you move into a PDSA, Plan, Do, Study, Act cycle. Sometimes folks refer to this as a PDCA cycle, Plan, Do, Check, Act. Same thing, doesn't matter, different words. So steps in the science of improvement model. Step number 1 is forming a team. Change can't be driven by just one person. The needed changes can't be identified by just one person. So you want to have team members who are familiar with all different parts of the process. So for example, if I'm running a social service agency and I want to make a change in our intake process, I want to be a part of that. I want middle managers to be a part of that. I want to have a frontline worker or a couple frontline workers be a part of that team. We want to have all bird's eye, we want to have all views into the process in order to get the best information and develop the best change package. The next step is setting your aim. What are you trying to accomplish? That sounds pretty simple and straightforward and a no-brainer, but actually a lot of folks make critical errors in setting their aims. And we're going to talk about how to set a good aim statement in a little bit here. But aim statements are time-specific and measurable and talk about who it is you're trying to make the change for and how. Then you need to establish your measures. How are you going to know if the change you've made is making the difference that you want it to, getting you the outcomes that you want? So you need to set your measures ahead of time, not in the middle of it, not after the fact. Set your measures to know how you're going to quantify whether or not the change that you've made is leading to an actual improvement. Then select your changes. What are you going to do to get to that improvement that you want? And again, these can be, depending on what your aim is, these can be small process steps, or these can be big system changes. Then once you've identified your change, you've established your measures, you have your aim, you don't start by implementing a change agency-wide or organization-wide. You start with a test. See if you've got your theory about, here's my change, I think it's going to get me this outcome, but test it out. See what happens. And this is where your PDSA cycle begins. You've done your planning. Now you're going to do some do. You're going to test it out. Then you're going to check or study what you did and see if it got you the change that you wanted. And then you're going to act. You're going to make changes based on the information you got back. Yeah, this worked great. Let's expand it out farther. Or it kind of worked, but it ran into, these challenges, and here's how we could adjust it, and go back and study again and see if those adjustments made the difference that we needed them to. So once you've gone through a few PDSA cycles, you've really tested and refined the change, then it's time to implement, first on a smaller scale, then more broadly when you move into your spread phase. So I mentioned 3 key questions in the Science of Improvement model. So 1, what are we trying to accomplish? 2, how will we know that a change is an improvement? And 3, what are the changes we can make that are going to get us that improvement? And this is really about creating your aim statement. Once you have that, you move into your cycle of plan, do, study, act. It is not a one-time cycle, it is an ongoing cycle. And even after you have spread your change across the organization, it's meant to be a continuously improving cycle. It's not completed and you don't do it anymore. It's meant to be an ongoing way the organization operates. So I'm going to go through some tools and some useful tools around creating a strong aim statement, because that, of all the takeaways from today, quite frankly, that's the most important and where most organizations end up taking a misstep. So aim statement, it's a clear, explicit summary of what your team hopes to achieve over a very specific amount of time, including the magnitude of change you want to achieve. It guides your work because it says, here's what success looks like. And research shows again and again and again that teams who develop a good, strong aim statement perform better than teams who don't. Aim statements are supposed to be SMART. SMART is an acronym that stands for specific. Is it precise about what you want to achieve? For example, have you identified a target population? You have to get really specific and not talk generally, because you can't measure generalities. Is it measurable? Are the objectives measurable? How are you going to know whether the changes resulted in improvement? What's your way of measuring improvement? Is it achievable? Is this a pie in the sky aim statement? Or is this connected to reality? Is it doable in the timeline that you've set out for yourself? Are you trying to do more than you're actually going to be able to do? Could you do more? Are you not trying to do enough? Is it realistic? Do you have the resources that you need to make the change you're setting out for yourself? The people, the time, the support. And then is it time specific? There should be an end date. I want to achieve this change for this population by this day. It can't be open-ended, because then you don't know if the changes that you've made have helped you get there. So here are the questions that you need to ask yourself when you and your team are constructing an aim statement. You've got to be really concrete about the goals you want to achieve. Be really clear about who's going to benefit from the improvement. Who are you serving with this change? What will be done? Is what you're proposing to do supported by evidence or experience? Are you just making it up? Where is the change going to occur? In what part of your organization or your process? Where is it going to start and where is it going to stop? Both are equally important. And really, what are the boundaries? What's in scope for your change? What's out of scope? So here is an example of an aim statement that sounds nice, but is a weak aim statement. Childhood asthma is a leading cause of emergency department visits, hospitalizations, and missed school days. We will increase asthma prevention programs so that children in our region have better health and education outcomes. Having worked in the nonprofit world for many, many years in past lives, I can assure you that I wrote aim statements just like this for foundations when applying for grants. I now know that's not a good aim statement. If I had taken this tool and used it to craft my aim statement, what am I going to do? Who's it going to be for? By when am I going to get it done? To what degree am I going to do it? And then put it all together for a full aim statement. I could have had an aim statement that was strong like this one. So in this example, talking about the same issue, childhood asthma, we've clearly identified what, okay? We want to create some sustainable strategies for improving asthma prevention. For whom? Not the world at large. We're going to start with 10 elementary schools in the county. By when? This was going to get done by June of 2016. By how much? Okay, 30% of the schools are going to have staff trained. 40% are going to have a professional who's trained to provide education to students and families. And then 40% are going to have programs for outreach to parents around the impact of secondhand smoke. You put it all together for your aim statement. Very specific, very concrete. I've got clear measurements. I'm going to improve by 30%. I'm not just saying I'm going to make it better. I'm actually putting a number down. And presumably this organization has done their research and knows that they have the resources in order to make these changes possible. This is feasible. This is not just, they don't have any resources. This is just what they'd like to do. So sometimes it can be hard for a team to figure out their aim statement, figure out what change they want to develop. And so there are other tools that can help you get there. One of them is a cause and effect diagram. So a cause and effect diagram, it's also called a fishbone diagram because it kind of looks like a fishbone. It helps team figure out, okay, what are the causes that are contributing to this outcome or this effect that we don't want, that we're trying to get rid of. It's just kind of, you know, there's a graphic display of the relationships between them. And the diagram has you list out causes under categories of the materials, the methods, equipment, environment, and people. So here is an example of a cause and effect diagram. We can see over here on the right side that the outcome that we're trying to understand, the outcome we want to change, is there are long test result times. It takes a really long time to get test results. That's a problem for our patients. We want to change that. And so as a team, we put our heads together and we map out, okay, in these categories of people, environment, equipment, methods, and materials, what are the contributing factors, right? So in environment, there are transcription errors. Clocks don't always agree. People are rounding up. In equipment, lab equipment can be slow. Sometimes we have capacity issues or tests have to be redone and that takes time. There can be malfunctions or poor training. We've also got challenges with our phone system. Methods, too many people, too many steps. people, here are all the people who are involved and the contributing factors that they bring. And then here are the materials. And sometimes the lack of availability or materials go bad are also a contributing factor. So doing this map helps a team sort of get everything out on paper in a visual diagram. Each of these contributing factors are not equal. You know, the inaccurate clocks is not as important as slow lab equipment, but until you map everything out, the team can't really start to begin to identify, okay, where are the places where we really want to dig in deeper. Another really helpful tool is a driver diagram. This is a common tool. Sometimes foundations will make nonprofits include a driver diagram or their theory of change when submitting an application. And these are frequently used in the healthcare world in QI teams. So it's another visual display that lays out a team's theory about what's going to drive or contribute to the change that they want to achieve. Shows the relationship between the aim, the primary drivers, which are the ones that really matter and have the most impact, as well as the secondary drivers that are a part of it, but not as impactful as the primary drivers. And then some very specific change ideas under those drivers for what changes can be put into place to get to your aim. Another way of helping a team get to the full picture and really see if your change package lines up with the aim that you want to achieve. And here's an example from the Public Health Foundation for a population drive around oral health. So over on the left side, you see, okay, here's their aim. Now, do we think it's a good aim statement? Is it specific and measurable? Not exactly. But for their theory of change, here's in general what they want to do. They want to increase the proportion of kids, adults who use oral health care, get education, prevention, and treatment. Here are their goals for doing that, making it more affordable, available. They want to prevent diseases of the mouth. They want to work on oral health equity. So then they move into their primary and their secondary drivers. The big picture drivers are there needs to be education about importance and urgency of oral health care. There needs to be better access to care and treatment. We've got big infrastructure and capacity problems, and then data monitoring and risk assessment is also a part of that. So those are big, meaty topics that it's hard to wrap your head around. How in the world are we going to change that? And that's why you move into breaking down the secondary drivers. And under their secondary drivers are their strategies for change. So first secondary driver is, okay, patient population and provider knowledge is an issue. So our attempt at trying to change those things are going to be to increase knowledge among those populations about comorbidities with oral health, do outreach to high risk and underserved groups, education about what insurance coverage is available, education to oral health and non-dental providers, and then education for families and caregivers, and so on and so forth through the secondary drivers. Lastly, another tool is a flow chart. So in the science of improvement, they talk about flow charts. In Lean and Six Sigma, they talk about it more in terms of visual mapping, but they're really the same thing. It's just a step-by-step representation of a patient moving or a client moving through a system from coming into the system to exiting it and all of the steps in between. Again, you need a team. This is not something that can exist in one person's head. It's a missed opportunity if it's only pulled out of one person's head. And going through this process creates a shared understanding for the team and identifies, just like we said for the Lean and Six Sigma, identifies steps in the process that aren't necessary. Maybe they're causing duplication, unnecessary work, or there's some communication gap or breakdown. Here is a really simple example of a flow chart of a patient coming into an ER with acute symptoms, and just depending on their symptoms, which path they go down. So the Institute for Healthcare Improvement, for those of you who don't already know about them, I highly, highly recommend. It's ihi.org. I've shared with BHT this toolkit, and in the toolkit, they give you worksheets for doing and instructions for developing a cause and effect diagram, a driver diagram, your flow chart. There's a PDSA worksheet that helps you step by step walk through the steps of planning, doing, studying, and acting, as well as some other tools for using data to get a better sense of where you've got problems in your process or that are getting in the way of the outcomes that you want. In addition to this tool, I also shared the Care Transitions Network for people with serious mental illness developed what I think is a really wonderful quality improvement toolkit, especially for any of you who are really new to QI and really want to develop a QI program in your organizations. It's written in plain language, it's well laid out, and it really walks you through step by step what you need to do and think about in order to build a quality improvement program. And it draws from the work of IHI. So it's using that science of improvement model and approach, and it's just got it in really nice, simple, plain language. So lastly, before we move into some Q&A, let me just reiterate some key themes from this and talk about some tips for success. So any good QI model is going to have these elements in it, right? So there's got to be an emphasis on leadership to hold people accountable, to communicate the vision and strategy, and eliminate any barriers to improvement. That regardless of what model you use, that's always important. Leadership really matters and sets the tone for how seriously an organization will take the change initiative and the work needed to measure and continuously improve it. There need to be clear goals, got to have a strong aim statement or aim statements. Sometimes it's not just one. The use of measurement and analysis to identify issues and guide decisions. This isn't about a group of folks just sitting around a table and saying like, well, I think our problems are X, Y, and Z, and then deciding which one to focus on. That may be a piece of the puzzle, but the complete picture is really developed when you couple what you think you know, what you and your patients or clients experience, and what data you have about how the system does or doesn't work, or what outcomes you are or aren't getting. There need to be transparent metrics. Everybody's got to know what it is that's being measured and how it's being measured. And stakeholders really have to be participants and audience for the improvement process. Like people have to be brought in the tent for change, not just watch it from the outside. QI models have to be patient or client centered. This has to be about how are you improving the work you do for the people you are serving, not how are you improving it for yourselves. And it needs to use structured iterative processes to implement improvement interventions. And iterative is underlined because it is the most important thing. Iterative means you're not going to ever get it right. You're going to continue to work on getting it right. And change is going to be iterative. And the moment you stop wondering whether or not you're improving and examining how well you're doing is the moment when you stop improving. And they use many of the same tools to support the analysis and the implementation. There's a map, there are metrics, there are data. So to have a successful quality improvement process, I would call out 3 key things. Just as with your overall change management initiative, there's got to be a priority on communication, engagement, and participation by everybody who's impacted by the process, either the people who are part of delivering the service, no matter how small you think their role is, to the people who are actually receiving the service and whose outcomes you want to improve. Another really important piece is that your change package has to have quick wins, right? You have to start with small scale demonstrations. They are easier to manage than trying to do everything at once. And they also are really important because they inform the change. If you do a pilot and a test, you get to see what works, what doesn't, and develop some ideas for how to make it stronger. You get some quick wins along the way rather than trying to implement some large initiative across the whole organization and not know whether or not the impact you're trying to make is achieved for years down the road. And again, just a reminder that quality improvement is a continuous iterative process. You're going to make frequent corrections along the way. That's good. If you find that you are making a lot of corrections along the way, that means that you have a quality improvement program that is doing what it is designed to do, and it will help you strengthen your strategy. So with that, I know that was a lot thrown at you, and some folks here may have a whole lot of experience with QI, and other folks it may be a new topic. So I'd be happy to answer any questions that you have.
You know, Kathy, while folks put their thoughts together, and I would love to hear an example from your experience and maybe a particular model or tool that you used that you found really helpful.
Yeah, so I am a big believer in the IHI model. Used it pretty extensively in Oregon. I've been using examples of change from when I sort of led our kids' health coverage program and all of our eligibility and enrollment offices. And so one of the big changes that we needed to make was in the application process. The application to get health coverage was way too long. People were being deemed ineligible when in fact we found out they were eligible. So the system wasn't working. So we started with our aim of, okay, we want to reduce the rate of eligible applications that are deemed ineligible. Sometimes they were ineligible simply because they timed out. The process was so cumbersome that you hit 30 days and we frankly didn't know whether you were eligible or not. The process just stopped because it was so cumbersome, you didn't get through it all. So we laid out all of our aim statements. We mapped out the entire process from start to finish, including how folks heard about whether or not they were eligible, the ways in which they could apply. Could they apply online? Could they go in person to get help, to filling out the paper application? And then all of the steps that the eligibility staff took from receiving the application down to, you know, did it come in? Was it scanned? Every single step along the way. It was a cumbersome process, but mapping out step by step by step by step by step helped us really identify, okay, what are our measures that we're going to look at? How can we streamline this process? What questions are we asking in the application that we don't need to be asking? We don't know why. They're making more work for the workers. They're making the process harder for people who are applying. They are bringing no value. Deleted those. And through that process, ended up, it took a good year. Through that process, ended up improving things for our clients. More eligible people were enrolled faster, which is what we wanted. We streamlined the application. It was, I think, 30 pages. We got it down to 5. And in fact, I have a really good example of, you know, making sure that you do your planning and your data gathering around that, because before I had started, the agency director had said, knew that application processing was a problem, knew the application was too long, and just said, I want a new application. I want it to be 5 pages, right? Sounds really good to me. Sounded good to me when I was an advocate on the outside. But then once that was implemented, we found out, okay, staff got it down to 5 pages, but we actually made our processing times worse for a whole subset of folks because there was information that they actually really needed that then they had to get as a second step. So made the application a little bit longer than 5 pages, far less than 30, but a more effective application that didn't require any duplication or additional work in order for an application to go through the process. So that's just one example. I have used this many, many times. I am not a processy person. as Cherise can attest to. But I am a believer in this process and the need to go through it and sometimes get down into excruciating detail in order to get where it is that you're trying to go.
Thanks so much, Kathy. Appreciate the real example, and I agree with you. The map, the limited amount of mapping I do, because I think we're very similar in that way, it is incredibly impactful and helpful. So really appreciate that.
It's the kind of thing where the minute someone says we have to do mapping, I roll my eyes and think, oh my God.
Yeah.
By the time it's done, I realize, oh, this is incredibly useful.
Yeah. Exactly. So folks, would love to hear your questions. Please utilize Kathy while we have her. And so if you have, please speak up, or you can type in the chat. But before you jump off, we do ask that we have a poll ready to go, and Sarah's got it ready to go. We just ask that you fill out the poll so that we know whether we're hitting the mark in regards to really being relevant and respectful of you guys' time, and you're learning something, because that's the important piece. So.
Yeah, and I would say if you have time, add into the chat or shoot an email to BHT about what's a change that you're trying to implement in your organization right now. Like and it can be big, it can be small, it doesn't matter. But it might be helpful to know, to think about, are there future TA offerings or tools that are available that we can just post on the website that would be helpful.
So we're seeing that the content is hit the mark. Would love though, as I heard Kathy offer up her continued expertise. Is there a place or something that, as you folks go through an enormous amount of change, is there something that would be helpful for you as an organization to continue going down that path? That would be really helpful for us, because then we can help plan and hopefully help support you as you go forward.
Yeah, and I would add to that, Cherise, that it's at some, the overviews are great. At some point, you really only benefit if you start to see practical examples. So if there's anybody in the region who's in the middle of developing a change packet or whatever stage you're in, sometimes having some peer learning and shared examples or shared problem solving can be really helpful.
Yeah, Jesse from YFA, the AIM statements, obviously you folks who enter into contract with us, we do require AIM statements and milestones. I think you guys are becoming just as much experts as we are, actually, as we work through that AIM statement. But as you were saying, Kathy, and I'm guilty of it too, back in the day, we just come up with these grand, we're going to do blah, blah, blah.
I'm going to make the world better.
Yeah, right. It wasn't measurable. It wasn't time specific. It wasn't really smart, right? It wasn't well thought out. And so now all of our partners are going through that process, and I think are really hitting the mark. So I really appreciate that. Any last questions from folks? Thank you all for the positive comments. Appreciate that as well.
Thanks, everybody. I'm going to miss spending my Thursday lunch hour with you.
Oh, we can come up. Don't tease me. We'll come up with something. Just kidding. No, thank you so much, Kathy and Ricky. Really appreciate you guys doing it. I always gained a lot, and I really think that these trainings were exceptional. So thanks so much.
Good. Thanks all. Have a good rest of
All
your
right,
day.
folks, go have a good day and a good afternoon, and we'll talk to you again soon. Thank you.